Good afternoon. First, I would like to offer very warm greetings in solidarity to the global leadership of the People's Health Movement and our comrades from Spain who are with us today, and our audience from different regions in the world. Accompanying this process of the beginning of the launch of the Global Health Watch 6, this process of collective building, which has been scientific, intellectual, and political, is the outcome of historic work in rapidly changing contexts of the reality of world health, of the conditions, living conditions of our peoples, and the workers in indigenous communities, Afro communities, women, and other groups with different sexual identities across the world. This is the outcome of an effort that seeks to identify the main challenges that we are facing at different times. To the extent that the People's Health Movement has been a process constituted by the free will of many activists from different regions of the world to respond, firstly, to the challenges of economic inequality, lack of symmetry, social and cultural exclusion, and that determine without a doubt the health of the people, the communities, the world in general. In this way, all during these changing situations, the activists of the People's Health Movement have been able to interpret these realities, denounce them to the world, and challenge world hegemony and provide guidance to raise up our energy, our struggles, our awareness in the search for transformation of the realities overwhelming us around the world. That is the effort of the People's Health Movement. I would like to invite you to join this process of this public launching. This is not the only one. It is just the beginning of a dynamic that seeks to bring together the wills of all of us to face the challenges that we are going through. Global Health Watch has that intention. It reflects the living spirit of our struggles, our demands. It seeks unity in action in all the different ways that different peoples of the world carry out their struggle, in this sense of debate, of confrontation, all the time against the struggles that we face and the challenges we face. With these words, I would like to make a call to all of you to begin a road of public discussion of the development and construction based on the content reflecting our reality, which is in the Global Health Watch book, of the People Health Movement. Thank you so much for being here, and I hope that all of us together will be able to move forward on the paths of struggle that we are taking. Thank you. Good afternoon, everybody. And each and every one of you, my name is Manuel Espinel. I'm a professor of sociology at the Political Science School at the Complutense University of Madrid, Spain. I would like to start with a small story. In the mid 1980s, I don't remember the date, and I refuse to say so because I don't want to show how old I am, but there was somebody who was very important to me when I was studying. And he was a union member and activist, and his name was Roman Vega, who is here with us right now. And Jaime also remembers him from the San Juan de Dios Hospital in Colombia. And due to the vagaries of life, Roman is now the global coordinator of the People's Health Movement, and I am a professor of the Complutense University in Madrid. And this coincidence over 30 years ago has brought us all together here today in this auditorium in the labor school in the Complutense University in Madrid. On behalf of our dean and on my own behalf, I would like to repeat a warm welcome to each and every one of you to this event. I would like to welcome Andres, Hani, Hugo, Josna, Adipika, David, Kiara, Sunder, Susana, Manuel, Alexis, Carmen, Virginia, Sulakshana, and all the others, and anyone who I may have accidentally left out. I want to welcome all of you from the PHM to the Colombian, Complutense University in Madrid. Welcome. I hope that you've all feel welcome. And I do want to apologize for the dean's absence, which was beyond her choice. And I want to think of this as a type of simulacrum. In the global and southern parts of the globe, things have to change. And likewise, we have had some personnel changes in the Complutense University to decolonize knowledge between the global north and global south. And this has created a good space for this meeting. This could have been just a simulacrum between the global south and the global north. And we bring it to you in the sense of decolonizing. We do not want to exercise extractivism of knowledge. Instead, we want to share among all of us. Given the changes that Roman has mentioned, and with these words, I would like to start again, reiterating my welcome to each and every one of you.
I don't know if somebody there is a message in the chat about people not being able to access the Zoom. If somebody can take care of that. Thank you. And I will ask the panelists to introduce themselves as they start speaking. So the first panelist, Ron, is joining from Ottawa. Ron, you have the floor.
Okay, thanks very much. Thank you to from Roman and from Mauricio, and thank you to Chiara. Now, it's my pleasure to sort of give a very brief overview of Global Health Watch 6, which we consider the definitive voice for an alternative discourse on health. And this is the 6th edition. And I'm pleased to say I've been involved with Global Health Watch all the way back from the very first edition that was published 16, 17 years ago. Next slide. So a few things about Global Health Watch 6. It was called or subtitled In the Shadow of the Pandemic. We actually began to lay out and develop the book before the pandemic struck. So we had to really look and sort of then retool how we wanted to approach and analyze what the impacts of the pandemic were on global health. Huge number of authors, 110 authors from 28 countries, and it amasses now to 468 pages, and I just checked. It makes it the longest Global Health Watch in the whole series. It was a pleasure to co-edit this along with Chiara Bodini. We had an international, regionally representative editorial group, and we worked alongside many other activist NGOs with which we've long partnered. Sadly, but I guess also compellingly, the book is dedicated to Amit Sen-Gupta and to David Saunders, both of whom passed during the period of time when we were producing it. Next slide. Oh, can we have the next slide, please?
It's there.
Oh, I'm not seeing it, but that's okay. Anyway, moving on. The book follows the tradition of previous Global Health Watches. It's divided into a number of sections. The first section is the global and political and economic architecture. So it takes the global health temperature of the world. The next section looks onto health systems, drawing on PHM's long historic interest in health for all. The third section goes beyond healthcare, what we now call social determinants or the social determination of health. The fourth section is watching. It's about global governance, and we try to appraise and look critically at the different institutions whose behaviors and policies affect health at the global scale, right down to the local scale. And there's a concluding chapter, which is a rallying cry for activists everywhere that draws upon all of the experiences of successful campaigns, activist struggles, actions of resistance that the entire book encapsulates in its earlier chapters. Now, the pandemic, of course, upheaved much of our global and political architecture. So speaking to that, the first chapter locates much of this upheaval in a continuation of three existential pre-pandemic trends. We're quite familiar with them: widening economic inequities, worsening ecological impacts, and growing movements of people seeking relief from poverty, conflict, climate change, or all three. COVID-19 made it impossible to ignore the extent to which our recent history of neoliberal dominance placed so much of humanity in peril. The irony is that the ability of the rich world to publicly finance many of its pandemic-affected businesses created so much new money in the unregulated global financial space that those in a position to capitalize on it, the already millionaire and billionaire class, they grew much, much wealthier. Now, for a brief period, a collapse in the global supply chains slowed or shut down huge portions of fossil fueled industrialization, and the planet remarkably breathed some momentary relief. But this relief was very momentary, with 2021's sixth report of the Intergovernmental Panel on Climate Change warning us, and we've heard this warning over and over again, that we have only a few more years left to avoid a catastrophic tipping point. The policies dealing with the millions of the climate imperiled, conflict displaced, refugee seeking, or poverty fleeing populations are still failing to protect the most vulnerable. But this chapter, although it covers those horrible existential health crises that we still are living with, it also offers some signals of positive change. In the wake of rich countries spending to hold their economies and societies together over the past 2 years, there's finally talk of national and global tax reform. We have a minimum proposal of 15% global corporate tax, to which many countries have agreed upon. Now, it's too low. Companies might still be able to dodge it, and most of the revenues will unfortunately go to the global north. But it is at least a start. Movement on marginal income and wealth taxes is desperately needed. There's some progress here too, perhaps not enough, and the amount of untaxed income as a proportion of overall global economic activity continues to increase year on year, rising from $30 trillion in 2002 to $75 trillion in 2019. We do not need to have so much untaxed wealth and income floating around the world, not being used for socially important global public goods. So there's no shortage of wealth to help solve these three existential health crises I talked about, only gross unfairness in its distribution. Now, meanwhile, coming out of the pandemic, countries are tripping over each other in a rush to be green. And even if the green economy measures are limited and from a planetary ecosystem perspective, they're deeply flawed, again, they nonetheless create change platforms that health and environmental activists can seize upon. Unfortunately, polarizing politics and the rise of autocracies are creating barriers to many governments' commitments to act on our climate crises. And Russia's invasion of Ukraine is having many nations pivot back to fossil fuels as they pursue energy autonomy. But as chapter A3 goes on to argue, our human societies have little choice but to embrace the concept of degrowth and the creation of a post-growth economy. Now, degrowth is not no growth, since many poorer countries still need some growth to achieve healthy living conditions. What it does mean is a managed downscaling in overall human consumption by putting the global north and wealthier people in the global south on a strict consumption diet. No more fast fashion, no more endless new cell phones or electronics, no more retail therapy where buying more and more stuff is supposed to make us feel better about ourselves. Now, such an environmentally essential consumption diet will require a radical dethroning of capitalism's intrinsic economic model, which is based on the mantra of growth, growth, and more growth. And that in turn is based on the speed with which new things are produced and consumed, energy is expended, and commodities tossed onto the rubbish heap. Now, there are multiple alternatives to this model being played out at local scales, from alternatives to capitalism's metrics of growth, the gross domestic product, to developing no-waste circular economies, and from labor market reforms to an emphasis on proper valuing of low resource consuming care work, the kind of work that proved itself to be of such importance during the pandemic. Now, efforts to transform an excessive and inequitably consuming world will almost certainly arise first in those local spaces where people live in close harmony with one another and with a respectful caring for all living things. And that is also the font from which progressive global health activism flows. Thank you.
Thank you very much, Ron. Now we have Sulakshana. Will you also introduce yourself when you start speaking?
Hello, everybody. My name is Sulakshana, and I'm from PHM India, Jan Swasthya Abhiyan. I'm also the coordinator of the Health Systems Thematic Circle, and also currently the co-chair of PHM Steering Council. So I will be presenting or speaking about the chapter 1B, which is on universal health coverage and the primary healthcare divide. And as we all know, UHC or universal health coverage has become one of the, major health strategies, in the mainstream policy and health dialogue, which is being pursued by global health actors and by countries. And its discourses driven by organizations such as the World Health Organization and the World Bank and other global institutions. So the genesis of universal health coverage was already discussed in the previous global health watches. And the analysis in the previous reports basically highlighted the difference between, what is meant by universal health coverage and the difference between that and comprehensive primary health care. And so just to remind ourselves, when you talk about comprehensive primary health care as written and espoused in the Almaty Declaration, it spoke about preventive, promotive, rehabilitative healthcare with a prominent role for community participation, community health workers, and also a role for governments to be responsible to provide these services. In contrast, the UHC policy approach focuses simply on financial protection and argues explicitly, for public but single payer financing, but not necessarily a public provider or public provisioning of health services. And so in a sense, the UHC discourse, especially, the dominant UHC discourse, seems to be favoring market based on neoliberal reforms. So the chapter basically, traces the development, the policy developments within UHC during the period 2015 and 2020, and reflects on the implementation and driving the its implementation and driving the global health agenda. It also touches on the pandemic, because as we were finishing writing the chapter, we were into the pandemic, and we've discussed what learnings or what priorities in terms of financing could the pandemic bring forward. And then it is the chapter assesses in more detail how UHC as a concept is being implemented, especially in lower and middle income countries. And it does it in a critical approach, in a critical manner, because there is a problematic approach in the way UHC is implemented with a focus on purchasing of services from the private sector through health insurance schemes or other kinds of public-private partnerships in which the public, the money is public, but the provider is from the private sector. And then we go on, and just to add that, this chapter So the co-author, and the other contributors of this chapter was Remco van der Pas, and also, and we took from a lot of the documents of various networks which are involved within PHM and the health systems thematic circle. So we tracked some of the major developments, for example, the UN high-level meeting on UHC that happened in 2009. We also highlight how within UHC policies, the health workforce, is not, is taken as given, and the UHC policies basically focus on financing without at all looking at the way health systems need to be strengthened, and with the health workforce as a core component of that. We find and we go on to give examples in terms of the implementation of UHC, the universal health coverage model, in strategic purchasing through publicly funded health insurance schemes, in which we see that this new wave of insurance schemes under universal health coverage, which is mainly being implemented in countries of the global south, are very different from the way social protection or social solidarity has been visualized in high income countries. So this new wave of insurance schemes, basically the rationale is to reduce financial burden through efficiency, quality, competition between providers, and giving a choice to people. So really using a lot of the neoliberal language and concepts in order to promote these schemes, and there is an explicit objective of favoring the private sector and the commercial health sector in the objectives of such schemes. And it is also, the implementation is supported by a lot of the global actors, for instance, the Gates Foundation, philanthropicapitalists such as them, and the World Bank, the ADB, and many other such agencies which focus on developing capacities for strategic purchasing of services from the private sector. And when we see, especially, we give some examples of countries such as India, Indonesia, Philippines, Morocco, Kenya, in which we find that, the failure of such publicly funded health insurance schemes in low and middle income countries is mainly seen in the dominant model of purchasing clinical care from the for-private sector. And we find that, and we discuss how private provisioning of healthcare really destroys any advantages of public financing of healthcare, and how coverage in Asian countries, especially, we find there is coverage through insurance schemes, which has been increasing. However, it does not result in financial protection. It does not, result in equitable access to health services. In fact, there have been patterns of unnecessary, surgeries such as hysterectomies and cesarean sections, which have happened and which women have been subject to, as because the private hospitals want to make money out of these insurance scheme. And so insurance as a mode of financing and incentivizing hasn't really worked in the public sector, and it has actually exacerbated the problems that people face in the for-private sector. And as a result of this funding going to private sector, for instance, in India, the National Health Insurance Scheme that we have, more than 75% of that money goes to the for-profit private sector. And that means, less and less money is available for investment into the public sector, which in fact, caters to the most vulnerable and marginalized communities. It caters more to indigenous communities, to families living in rural areas, and other marginalized groups. And in the chapter, we also look at how some of the global financing initiatives, such as, especially of countries, for instance, UK aid, and, Dutch aid, etc., and other public-private partnership initiatives really, boost the private sector in, countries, for instance, in Uganda or in other countries, instead of, using the money in strengthening the public sector. And we also give a caution, that this whole discourse of, purchasing services from the private sector rather than strengthening public provisioning of health services has really now, so there are attempts to, do this within primary healthcare, which till now, especially in the global south, has been mainly, publicly provided. When you look at the comprehensive primary healthcare, preventive, promotive health services, immunization, and in COVID-19, we clearly saw how it was the public sector that basically provided, all the services, from management of COVID to screening to preventive measures to vaccination to testing. Everything was done by the private, majority by the private sector, and and the public sector really failed to respond. And when it did respond, it was very exploitative, and there was a lot of price gouging, and people had to pay a lot of money to access care. So we end the chapter by emphasizing how this discourse is now being used to, promote privatization of and commercialization of primary healthcare too. And we have some recent documents, such as the Lancet Commission on Financing of Primary Healthcare, and we have a previous WHO document on operational framework of primary healthcare, which basically uses the same language and the same terminology to promote purchasing of services, and basically saying that the government, there should be a purchaser provider split, where the government should only, give money and purchase services, but not be the main provider, and it should mainly be the private sector from which the government should buy, so they use that language, purchase the services. And we also give examples, of how, of very recent initiatives on deprivatization or remunicipalization, and how activists all over the world have been resisting such, neoliberal agenda. And I think, and finally we propose, and we propose that all of us together, whether we are social activists, academics, social movements, campaigns, labor unions, we need to come together in solidarity. We need to remain, really vigilant of all such, things that are going on, and document them and scrutinize the evidence towards further commercialization of healthcare, examine and, critique any, especially the dominant narrative that really promotes, profit over people. And wherever these dialogues get captured by the private sector, as we've seen in WHO or in other global institutions, to really resist that, and also, at the country level, demand higher investment in the public sector, and strengthening of the public sector, demand expansion of public employment, and especially in the global south, and that's, very critical, aspect. And it's really essential to shift the normative, environment from a market-based commercialized perspective of healthcare to a system which is based on solidarity and human rights and public accountability, and that ensures health for all people. Thank you.
Thank you very much, Sulakshana. So we are happy to share a small video that we made to spread the word about Global Health Watch. And thanks to our friends in Madrid from Medicus Mundi, we also have it with Spanish subtitle. So let's see if this works. Sometimes Okay, I need to share the screen though. Yeah, okay, just wait. No, the audio will be fine. I just need to share the screen. So just, where is it? This. That one. Okay, I hope everybody can see it. Can I go? Yes, ready? Okay.
Global Health Watch 6 is the latest edition of People's Health Movement's flagship publication that's released every 3 years in collaboration with like-minded organizations. The book's authored by a worldwide network of activists committed to the goal of achieving health equity within and between countries. Written in the shadow of the global pandemic, the book describes how and why the pandemic deepened inequities in access to health and healthcare. It also talks about ways of creating a fairer, healthier, and environmentally sustainable future.
Ensuring equitable and quality health services for every human being on earth is a long-standing goal of PHM. Unfortunately, debates on universal health coverage have taken over all other healthcare reform discussions, leaving the goal of achieving comprehensive primary healthcare on the margins. Countries are expected to generate their own financing of health, something which is impossible for poorer countries to do. It also rids rich countries from taking responsibility for their exploitative politics and economics, which perpetuate health inequalities in the first place. Rampant privatization of the health sector simply provide new ways for investors to accumulate more wealth. The future of health and healthcare must be public.
Development model based on extractivism, growth, and consumption will continue to make everything worse, be it human health or inequality or planetary destruction. People in poor and indigenous communities will be the worst affected. In our book, we propose an alternative vision about how our communities should and could relate to each other and to the planet. We need to gather 8 different examples from territories around the world of popular resistance and hopeful stories of successful struggle.
With COVID-19 and ecological degradation intensifying inequities promoted by neoliberal globalization, Global Health Watch 6 offers important insights, ideas, and alternatives. It's a book of challenges and hope, of exploitation and resistance. It's a resource that I commend you to read, to discuss, and to share for its strategies for a fairer and healthier future.
Yeah, that was it. Yeah, we're very proud and thanks Jotna, our PHM communications officer who did a great job.
Today, 11th March is a very important and grim day, in a way, grim day for all of us. It's third year of the pandemic, many confirmed cases and deaths, officially. We know the numbers, 6 million deaths. This is an underestimation. And we know that for a fact, that
Where?
a study released yesterday estimates that 18.2 million people have died worldwide because of the COVID-19 pandemic. By the end, this is by the end of 2021, and many of this in developing countries. It's not just the number of deaths, but the...
Well, it's still related, so don't worry. Let's close. Okay, that's good. Cool. Yeah, Sangeeta, we like Sangeeta. Okay, so you can go.
Okay, so good evening, everyone. I'm Susanna. I am part of the People's Health Movement. I am based in India. I've been part of the Global Secretariat of the Steering Council and will continue to be involved with the movement in different roles. I work for the organization Public Services International, but this work on this chapter of the Global Health Watch I'm going to talk about is part of the work along with the People's Health Movement. So the chapter I'm going to share a bit about is about the COVID-19 pandemic and healthcare privatization. And here our starting point was that we could already see so much evidence, that's anecdotal evidence, that the privatization of health systems had affected the preparedness of healthcare systems around the world, and that was undermining the ability to timely and effectively control the pandemic and manage the health and social consequences. But we wanted to gather more evidence to have more solid information that we could share and systematize. And in that process, we also wanted to see how those processes were also seeing the emergence of new trends, of specific forms of roles that the private sector was taking in the health care sector. So we looked at different parts of the healthcare sector. We started looking at public health services and functions, and both the privatization that before the pandemic and then the trends of privatization during the pandemic. And in this sector, we really saw that over the last years, 25 years or so, the basic sorry for the conflict. The basic public health functions have been gradually eroded in high-income countries, in middle-income countries, in low-income countries, because the government was not prioritizing that area. It's not seen as an area that provides for resources, so it was kind of left for itself. So testing, tracing, data management, even communications functions were not covered adequately by the public sector. And as the pandemic came, many of them were outsourced to the private for-profit corporations. Communication functions were not, and were really left for no one to take care of them. And I think we've seen a lot of the implications of that when vaccines came around, where people in communities felt they didn't have the information that they required. Lack of trust with the public health system made that you have hesitancy in, for instance, going for the public health advices that were there, or also, for instance, for vaccines. But in other areas such as testing or contract tracing, really it was outsourced to the private sector. Testing was mostly a private individual responsibility. If you want to get tested, you go yourself. It's not part of a public health strategy, really. And that also means that the out-of-pocket payments are important, or sometimes health insurance would cover it, but it's not part of a public health strategy in itself. In contract tracing, it was, again, very often contracted out to private providers or in partnership with private providers. And what this also allowed is to have an amount of data that needed to be analyzed and managed that was just falling into the hands of the private sector. And there were a few cases where that led to controversial situations and to serious concerns, for instance, with the company Palantir that was working in the UK and in Greece, and where the Greek government terminated the contract due to concerns on the privacy of the data that was collected and opposition that was raised. So these are new elements of this question of who holds the data and the amount of health data that is available. Those trends are really increased a lot during the pandemic. So that's one of the elements I think that really emerged from that section of the book. In terms of the privatization of primary healthcare, we observed that in low-income countries, and especially in South Asia and sub-Saharan African countries, the predominant first point of contact that people have with the health system is very often, it has been weakened because of years of underfunding, and that this link is mostly held through community health workers. Those community health workers are women from the community that are most often unpaid, very informal, and they become this link that is left because the primary healthcare system has been weakened so much. With the rise of the COVID-19 infections, the role of these community health workers in monitoring COVID-19 cases became very important. So these community health workers became really central to the strategies of governments, but that doesn't mean that their working conditions were improved. So situations of very informal conditions of work meant that there was inadequate training, that there was lack of support and supervision, lack of PPE. In many cases, they were not even recognized as health workers that were supposed to receive vaccine or personal protective equipment. Increased workload. So really very difficult situations where we saw that the most vulnerable cadres of the health workforce were left to carry the cost of keeping the system running because system just hadn't been given the resources it needed. And another trend we saw is that in high-income countries, the digitalization and telemedicine of primary healthcare had already started coming in, but with a certain, drawbacks, or people were not necessarily too comfortable with it. And the COVID-19 period really accelerated this trend because when most public and private primary care practices had to downsize their services to fight the rise of infections, then this telemedicine, e-prescription, digital screenings became much more generalized, but without the regulations and regulations that were required. So we saw the emergence of unregulated private technology and of a spread of their use, which is a concern that is still remaining in that sector. We also looked at, of course, hospital provision and how the privatization of hospital provision affected the ability of governments to respond. Of course, the continuous privatization of that sector did not strengthen healthcare systems, despite the arguments from neoliberal theories. Instead, it made that component of the health system was really not ready for emergency public health responses. The resources in the public health system were not enough, and the resources in the private sector were not ready to respond. We kind of mapped a bit fragmentation, expensive and inadequate provision of services, alternatives to publicly financed hospitals, regional outsourcing, and these meant on the ground that there was a lack of adequate public hospital beds, ICUs, public healthcare workers, and that led to overloading the public health system and in many cases discontinuity of care for other services that were not being provided anymore. At some point, we saw also the emergence of certain reactions from governments, for instance, requisitioning of private resources, but all of those were generally against some level of reimbursement fee. And in most cases, government actually ended up allocating large sums of public resources to private companies so that the care for COVID procedures and treatment was outsourced to these private companies. So in many ways, I think in relation to selection, also presented a shift from resources from the public to the private sector. But the reaction of the private sector was also in stages, but reluctance to take possible COVID-19 cases, unwillingness to compromise on profitable services were very common responses of the for-profit hospitals in a first phase. Then there was a kind of a shift also at later stages where private hospitals were happy to use, to take COVID-19 patients because there was also a larger amount of money that were, that was seen as bringing resources to those companies. So we really, I think, managed to gather evidence of the implications of privatization before the pandemic on the ability to respond, and on how that had real implications for access to care. And we bring also the element of how we need to look at strengthening public healthcare systems as a prerequisite for controlling the current pandemic, but also as necessary investments for managing future public health threats and emergencies. And in doing this, the importance to increase, of course, public financing, increase direct public investment for new public infrastructure or the modernization of existing public facilities, ensure the empowerment and support, decent working conditions, and long-term employment conditions for public healthcare workers, the need for strict regulation of digital health services and big data, and there is a real regulatory gap there. And of course, the resocialization of essential health services, long-term care needs to be back into public hands. We had a case study showing how in high-income countries, old age care in the private sector had really led to situations of outbreak of in those facilities because of bad working conditions and the profit motive at the core of how those services were provided. So these are some of the highlights of the book, and I hope we feel like it's a useful tool for you to be able to think about those processes in your countries, and we encourage you to read the rest too. Thank you.
Thank you, Susanna. And we now have our final couple of panelists. So first will be Amulya. Amulya, please introduce yourself. I will just give you 1 second to set up the screen sharing. Do you see the slides?
Yeah. Yeah, I am Amulya. I'm Amulya Nidhi. I'm from People's Health Movement India, Jan Swasthya Abhiyan. I'm one of the national co-convener and also associated with the Ecosystem and Health Thematic Circle as part of that. So I'm going to talk what our thematic circle, how we bring in the chapter. So we basically talk, we believe that health, human health is largely a part of the nature as a whole. And we try to connect health with the climate change, we try to connect with the environmental health and the extractive industries and all that. And we try to describe in this whole chapter about the whole development model and extractivism and environment. So this is, and what are the various resistance is happening and what are the various challenges is happening. And in the past watch also we are committed to mention about the various whole declining trends about the ecosystem and health and all that part, and also the risk of climate change, water loss, extractive industries is all featured in past edition also, and the presently also we have featured about that. So it's a next slide please. So this is basically a collective efforts by many contributors and across various regions of the country. So I'll start with important quote with Gandhi had mentioned, Mahatma Gandhi: "Earth provides enough to satisfy every man's needs, but not every man's greed." And this is it actually happening in the name of land grabbing and resource and taking the natural resources across the globe. So as ecosystem and health thematic circle, we believe extractivism as a system through which mainstream development model operates. And extractivism is a model of accumulation that favors extractions of natural resources. And what we try to describe in the chapter, we compiled 9 case studies and 9 struggles in various parts of the region, and we try to put in that struggles and try to describe what is happening. And these are not a unique case studies. These are also the representative cases and is happening across the globe. So we started in this chapter about the whole debate about the whole development policies. What are the development policies and inconsistencies in the development policies that funds health, right to health with extractivism and deficit examples of resistance of extractive industries tied to the people's health movement. We also emphasize the whole need to strengthen the link, the link between the right to health struggles and anti-extractive resistance. So we try to also establish the link between in the entire chapter. We try to describe to that. The case studies which we presented are not unique. Rather, they are representative of hundreds of other stories. These are the 9 are just we collected about the representative samples. And we also learn about various different models which to challenge the dominance of extractives, developing paradigm models to promote rather than threatening collective well-being. So this chapter largely talks about these larger issues. Now I'm going to talk about few case studies, and my other speakers will talk about other case studies. So we have compiled the 9 case studies, and we are questioning ourselves whether it is development or destructions. We are talking about the development. We are talking about the grabbing the new mining projects are coming, new nuclear plants are coming, lots of things are happening, new companies are coming, but in the name of whether it is development or it is destructions. So we have stories of hope from Ecuador, from Argentina. Next slide, please. The whole issues related, struggles related to water issues in urban Argentina. We have stories about the resistance in Philippines, about the whole environmental defenders has been threatened. They have been harassed while protecting the environment and all. And also about how indigenous Swedish people are fighting for the mining projects. So also in resistance in Texas about the whole issues. So we have several stories, and based on these stories, we try to compile. So I am going to talk about few case studies, and more can be discussed in the chapters. Just as a representative, we have described what's happening in the Swedish law, which violates the indigenous rights. The important part about all the small, the indigenous communities, they are dependent upon the farming, they are dependent upon the fishing, how their rights has been violated. And it's important things when when the activists and they challenge this. It's also important, and the whole ILO convention, the Indigenous and Tribal Peoples Convention, ILO 169, which is binding on the signatories. Sweden has not signed it, and this is very important. There are many ILO conventions at which many countries have not ratified. It's largely related to environmental issues and the health risk of the people. So that's also, and also the whole conflict between the state, because the state want to grab the lands, and between the communities, those who are dependent upon environment and livelihoods. So these are the whole conflict have been, struggles has been happening, resistance has been happening on those. And also about, despite of they talked about the environmental health impact. There are many projects which are coming across the globe. They talk about the environmental health impact, but it's also important. It's not only the environmental impact in any project. It's also about the social, cultural, or health impacts. So these has been not highlighted in this whole things, and there are many research which predicts the negative social and health impacts of the minings. The second case studies which I'm going to talk a little bit. This is about the struggles, what is happening in the Philippines. This is about the Philippines Network of Environmental Central has talks about how there are many struggles across to protect the mines, protect the environment in the states, and how the state has been harassing the activists, and how the defenders has been struggling for the years for their struggles, and there has been murdered, there has been illegal arrest, detention has been happening, and series of hundreds of have been detained. So this is another kind of struggle, and this is not only the Philippines, it's happening in other parts of the country, it's happening in India and other parts of the country, whereas the activists and those who are the defenders, those who are challenging these companies or these minings or protecting the rights of the people, they have been harassed and they have been murdered and they have been threatened by illegal detention and all that. So this is also happening in, this is one of the examples, but this is happening in various parts of the globe. This kinds of harassment has been increased. The next, the last case studies, which I'm going to talk a little bit about from India. We know the occupational and environmental hazards is large, lots of them. So the workers, large number of workers are at risk of occupational health hazards. Those who are working in various mines project and also in the various factories, and there is most of them are indigenous people, and from last several years this risk of the informal workers has been neglected. So this is the whole struggle from last over 2 decades. The whole struggle has around this mines worker, mobilization of this worker has been happened. They established the issue of silicosis. There's occupational health result has been established by the pressure of this organization, mass organizations which mobilize the people, as well as to pressurize the government, as well as the whole through the judicial activism, the compensation has been paid, as also the notice from the highest court of the country has put a notice to the pollution control board and about warn them about the health and safety of the people. So this is happening, and there's a now rehabilitation plan has been developed, and this is through one struggle. There are lots of policies and rehabilitation plan across the various states. It is happening. So this is also one example where large number of workers has been exposed to this, but this is not the priority of the government. So this struggle has actually put pressurized to the government also, and ILO has also documented this as a case studies for the learnings. So basically, to conclude in this chapter, we talk about human health is a part of the health of the nature as a whole. We are dedicated to develop, strengthen the whole campaign against the impact of extractive industries, and these are the resources which is useful for the various struggle groups as well as the activists, and also to strengthen their struggles around people's rights, land rights, and forest rights. We appeal the various activists and their struggle groups to join us as a collective platform, so that as collectively we can resistance, we can challenge this all things happening. Our next colleague will talk about the other case studies. Yeah. Thank you.
Buenas tardes, muy buenos días a todos.
Good afternoon, good day to everybody. I am Emmanuel Burns. I am a professor in the Toronto University and a member of PHM Canada. As members of the Canadian chapter, we are required to denounce the extractive industry and the mining industry and the role of Canadian transnational industries. Between 15 and 75% of these transnational mining corporations are based in Canada. Most are listed on the Toronto Stock Exchange in my home city. And so why and how is Canada divided regarding the mining sector? Why is Canada so welcoming to the mining sector? First, there are financial incentives. There is a 15% tax credit for exploratory activities. Lax security laws and stock market regulations make it easy to raise capital by this industry, and federal governmental support channels support to mining companies through the Canadian Pension Plan and Export Development Canada, making the public complicit. There are also legislative and judicial failures. Canadian courts have historically dismissed, but through activism in the last 10 years, this has started to occur at a provincial level, not federally, however, but this has been a very important development. There are 2 cases right now, one that was filed around 10 years ago against Hudbay Minerals in Guatemala, where many of the people who were resisting Canadian mining companies in Guatemala were wounded or killed. And then there was a British case against forced labor in Eritrea, which was allowed to proceed in the British Columbia court. And the idea of corporate social responsibility for extractive company is practically a joke. Very quickly, you can see here the extent of Canadian mining corporations across the globe. This is a report produced by the Canadian government. We also have a problem with deadly diplomacy. Here we go. Along these lines, the federal government and Canada's development agency has funded projects to rewrite the mining codes of several Latin American countries, including Peru, and has supported repressive governments in Latin America, in Honduras, for example. And Canadian diplomats and politicians always support Canadian mining projects and also support trade agreements that facilitate Canadian corporations in their support for pro-mining strategies and against protests against these efforts. This is a huge problem. We recognize that ideological practices in the past and the present and white supremacy that have taken place in the global extractive order. There have been, however, joint academic papers written to support communities in resistance in particular. Research that we have done with activists has led to documentation of the harms that have been caused by these corporations internationally. And we have supported resistance against these effects, both in indigenous communities in Canada and Nicaragua and Greece and Ecuador. I'd like to close with a case study that talks about the relationship between a group in Cuenca, Ecuador, and support for a group that promoted a public consultation regarding water in 2019. So this was a collaboration between PHM in Ecuador and in Canada. And they filed a friend of the court brief talking about the impact of extraction in the region around Cuenca in Azuay and in Quinchacocha. Challenging the health impacts in Quimsacocha. And the impacts are described on the previous slide. But this was not initially supported. However, we did a number of actions in the annual meetings of the mining corporations in Toronto. Right before the pandemic took hold in Canada. This particular demonstration took place in the center of Toronto. And at the left, you can see the demonstration out in the street. But the comrades were also able to infiltrate the shareholders meeting. And they were able to talk about the case in Cuenca, Ecuador. So we tried to support activists in real time in Cuenca and in Canada, even though the case was denied. There was in February of 21 a public consultation in Cuenca, the third largest city. There was an agreement against mining and protection of the water in Cuenca. I just want to end with this acknowledgement from Cuenca, thanking PHM Canada and thanking nature and the peoples of Cuenca and the group Yasunidos. And we want to continue our solidarity not only with our comrades in Ecuador resisting Canadian companies, but also with people in Argentina and PHM in other countries.
We were able to show what Global Health Watch is about. First of all, it's a collective effort. So you heard some voices, many more contributed to the book. It speaks about health as something that has to do with trade, with commerce, with the private sector, with environment, with ecosystems, and with health systems, but not only with health systems. And also, it is very connected with the struggles. So the content of the book is nourished, and the analysis in the book are nourished by our struggles. And also, we hope, and it's been so for previous editions, that the book will nourish struggles. we want to keep space for debate. We have half an hour. We can go until 8:15. Then we will need to leave the room. So definitely we want to hear from you, especially from the people who are from the local people in Madrid and in Spain who are here with us. But just to, Ron mentioned that the book is dedicated to two of our dear comrades that are not here with us physically, Amit and David. We have books that with their, sorry. That wasn't planned. We have books of the things they wrote for and with us, and things that we wrote for them. You're welcome to take them. And also we have, this is Eduardo Espinosa. He's physically with us very well and struggling. This is about the struggle, liberation struggle in El Salvador. Again, it's there. And then this is a small book that Amit was involved in together with me and another comrade. It's about just a booklet about the struggle for health, sort of synthesizing the key vision and some of the analysis, but in a way that's more accessible. And we're happy that we'll have it in Spanish sometime soon. So, second thing, very important, all the previous editions of Global Health Watch are available for free on our website. Now, where is this edition? What is this edition? Surprise. No, no surprise. It's not coming out of the box. Unfortunately, we had problems in the at the border in the shipping of the books. They were supposed to arrive in Belgium and then to be carried here by our Belgian friends. Yeah, so we are sad about that, but we will have them soon. So you can purchase it now from the website. On our website, all the information is there. You can purchase it from the website of the publisher, but then we will have our own copies. People's Health Movement will have their copies, and we are planning launches in many places. And I know some people in Madrid already asked if they can have copies to have maybe another space to present the book, and certainly we can do that. So just be in touch with me. We can arrange that in many different ways. Yeah, that's actually what I wanted to say. So now the floor is open, and please take this chance. If you have questions about the book or the content, that's fine. But if you feel like sharing some of your struggles, and that's also very, very welcome. And you can speak in any language, more or less, but certainly in Spanish. Yeah, and but you need to speak in the mic for the interpreters. If people, sorry, we give we give priority to the people who are here in the room, but people on Zoom, if you have something to share, just maybe you can type in the chat, and then we'll get to you. Can you please introduce yourself when you start, and also remember to speak slowly for the interpreters.
Voy a hablar en castellano. Bueno, buenas tardes. Un placer estar aquí y ver de nuevo a Chiara. Nos conocimos hace unos pocos años en Bruselas y bueno, creo que es un buen momento para reencontrarnos y bueno, daros la bienvenida a todos los que habéis venido aquí a Madrid, mi ciudad, a España, mi país, y espero que os estéis, en fin, estéis disfrutando en lo posible con este día y con el trabajo que supongo que os ha traído hasta este momento. Yo soy Carmen Esbrí, represento a un movimiento que nació aquí en Madrid, que se llama Marea Blanca. Creo que estamos luchando todas y todos en el mundo por lo mismo, por la salud universal. Nosotros tenemos como primer objetivo la salud universal como derecho humano de todas las personas. El movimiento Marea Blanca nació en el 2012 cuando un gobierno conservador llegó al límite del neoliberalismo implantando un decreto que eliminaba la universalidad y que ponía las razones del mercado por encima de las razones de la salud. España tiene una ley, que es la Ley General de Sanidad, que a finales de los años 80 creó una estructura que se levantaba sobre la atención primaria. Eso que la OMS desde Alma Ata dijo que era beneficioso para la salud porque consideraba que era importante que se tuvieran en cuenta todos los determinantes y que se midieran por gente cualificada, que son los sanitarios médicos, y que se hiciera en el espacio cercano de los ciudadanos con métodos sencillos pero científicos y que supusieran un control permanente de la vida de los mismos en su entorno. Eso lo teníamos en España, pero eso se ha ido destruyendo y ahora tengo que decir que aquí en España, aquí en Madrid, se está comiendo el nivel de la atención primaria porque pretenden liquidar el sistema sanitario público que era universal, que tenía calidad reconocida, que podía ser mejorable, indudablemente, pero que era un elemento muy sustancioso para los...
But it was a substantial sector for the private health companies that want to gamble with people's health. I don't know how long I can talk, but I want to say that from there, we started Marea Blanca in Madrid, and all of the health people involved with public health came out and supported us. Citizens also supported us. Great masses of population came out to defend their system of public health. And after that, or at the same time, we created also the collective I represent, which is Marea Blanca, to support universal healthcare, primary healthcare in Madrid. And we've been struggling for 10 years to restore what we had in the past and to make obvious the evils of the neoliberal market. To illustrate, I said unfortunately, but not unfortunately, we did achieve many things, but over the years, we have also lost other things. And above all, we are losing absolutely the control, social control of the system, because the market has swallowed it whole. Right now, I have to denounce that the pandemic has also been a business opportunity for the whole world, and also here in Spain. The topic of the vaccination, we all know, has been a fundamental element for the dishonest and illicit and unethical wealth of the vaccination manufacturers and the pharmaceutical companies. We say that vaccines should be liberated and reach all points of the globe. We know it has not been so. It continues to not be so. And other things have allowed the excessive enrichment of few people in contrast to the precarious health of large sections of the population, including here in Madrid and Spain. So I understand that what we're doing is what everybody is doing in the world. I understand that there's substantial differences between some spaces and other spaces, but I also am taking into keeping in mind that the model is the same, and it is the model against which we must struggle. So I want to say to you is that we are here, and I want to make network with all of you, and we can link up our work. And thank you for coming to Madrid.
Here, yes. Again, please introduce yourself.
Hola, yo me llamo Juliana y estoy muy contenta.
I'm Juliana, and I'm very happy to be here. We are part of different organizations, so I'm not here representing any particular one. But what my comrade was talking about the White Maria movement, I have also been involved in different struggles to defend health and public health. One of them is universal health coverage that was promulgated in 2001, which actually got rid of a lot of the things that were provided in the Spanish health system, especially for immigrants. So there was only possible for Spaniards or immigrants to get emergency services. And so this movement continues, and it is made up of health professionals and volunteers in Spain who are supporting the immigrant population to get their rights recognized. So this is one area where the struggle continues. Another is a popular or health struggle, which is a public legislative effort. And this is a way that we have available in this country and in others to provide the public an opportunity to debate needs in the Congress. We need to have 500 signatures on a petition with all personal information and signature for these public initiatives. And the only people who can sign these petitions have to have Spanish nationality. And this is also being promoted. It's a process and a struggle nationwide, coordinated by an anti-privatization group. There's another struggle going on, and by a group, and I'm one of the users. I'm not sure if this is the word. Madrid is a disaster. It has more than neoliberal government. And let me talk about the autonomous regions. There are autonomous regions in Spain, to summarize, that have autonomous administration, and they have certain authorization, certain powers, and especially in health and education. The Ministry of Health has only very basic powers that they used during the pandemic. And in Madrid, the vision is that it is one of the most liberalized communities. Though most specialized care is provided in private services. So for the public system to provide specialized care, they need to have agreements with private services. And so this means I said that I did not want to go to the private sector, and I had an appointment in May. And so they set me up an appointment in the public sector in July. Thank you very much.
¿Quién más quiere hablar?
Okay, so we have Ricardo, I think, from the Zoom. Ricardo, would you like to speak? He's a
Bueno, no sé si.
Can you hear me now? Thank you. Hello, greetings. I am Ricardo Ramirez, and I am talking to you from Ecuador. I am the coordinator of the Andean sub-region of the People's Health Movement. And I wanted to just say two things. First, I want to congratulate you on behalf of our comrades for the production of the Global Health Watch, which it was something that was very important, and we needed to have it come out again because of what it represents. Because it is a report to the world of our struggles. And it is important to disseminate these struggles because around the world, they reinforce each other. Whatever our comrades do in one part of the world help what people are doing in other parts of the world. And second, I have received a lot of messages saying that people need the publication of the Global Health Watch in other languages, in my case in Spanish, for greater dissemination and making the content more easily accessible, which will enable us to be better informed and to participate better in the entire process. And all of us are very excited about the opportunity to participate in the production of Global Health Watch 7. And so we hope that the time between one edition and the next won't be so long, which happened between the 5th and the 6th. But I do want to congratulate everybody and the entire production team for this important publication. And to let you know that we are expecting to see the Spanish version, and we are hopeful for that. Thank you very much.